Let's sort of wrap up our whole discussion, and it just reminds me of just how smart you people are. I mean, what a great discussion, and everything that you have brought to this I know will be valuable to all that listen in. But I want to, Tony, and maybe start with you. Give me a sense of what do you think are the challenges going forward for TRK fusion targeting agents?
I think the biggest challenge is the obvious. These are rare, incredibly rare, and their rarity becomes even more problematic when you're not consistent in looking for them. Meaning something that's 1 in 100 or 1 in 1,000, if you just randomly pick every other patient that comes to your clinic and send for testing, then you're 1 in 100,000. Just by randomness alone. So, the one thing we have to keep in mind is that if you have a fusion, you're going to have a great response for patients who may not do as well on chemo. And for some patients, like one of the longest reported responses so far, there are many that are ongoing, is now almost 4 years. So we know that if patients respond, they can respond pretty well. So we want to find them. There's same thing with MSI high. I mean, same thing, frankly, with a lot of these alterations that are at the level of 1 or 2%. So we have to be consistent. We have to look for them consistently. So that's the biggest challenge. Louis was talking about, now these next generation agents that are looking essentially at those patients who fail because of the development of a mutation. Now we're looking at even a smaller subgroup of patients and how to salvage them and make a difference in those patients. And that also brings the question of those that are intrinsically resistant because they have the co-mutation. And how do we actually put all these together? I mean, frankly, it's not just multidisciplinary collaboration, it's also multi-specialty collaboration. I mean, we can't do it in GI, we can't do it just in lung or salivary, I don't know who the heck takes care of salivary. Cancer docs, I guess. So how do we bring everyone together to essentially, work on this? And that's one of the challenges. The other challenge is, of course, testing. We've heard a little bit about HC, FISH, RNA for fusions. DNA-based testing is problematic because it may miss some 25, 30%. And we know that the most commonly used one in clinic is actually DNA-based genomic testing. So you're missing on some of these patients. 30% of a very small percent is problematic. So the DNA-RNA hybrid assay is probably the best, but at the same time, it's the most costly and takes a long time. IHC and FISH are useful, but again, how many patients are you going to test for IHC or FISH to find that one patient? I mean, they're not costly. IHC is highly sensitive and specific, requires one unstained slide, but you're wasting a slide, and you may be wasting time when you need to find a lot of other alterations. So if we can find a really better way to do this DNA RNA hybrid sequencing more efficient or faster, so we can give the answer to our patient, and rely more and more on these liquid-based biopsies, refine them better, that would actually be the best bet to continue to move these things forward and eliminate some of these barriers that are prohibiting us from finding these patients, because they do benefit.
Jyoti, maybe you could comment for me. I mean, I hear so many comments from community oncologists and the like who are frustrated by the concept of broad, molecular profiling, and they're like, I never find anything, and they sort of get tired of looking because they don't see much value in it. What's your counsel to somebody who's having that feeling?
Sure. So these drugs and these targets certainly feel like unicorns, but if you don't look, you never find them.
You never.
And they radically change the outcome for these patients, their ability to get back to life, the improvements in performance status, the rapid diminution of symptoms. Like, it's really remarkable. Certainly just at the beginning of this COVID crisis, can you believe we just had a patient with really what looked like horrific disease, and then we found out she had an NTRK. Before we all went into hunker down, like the entire team was ecstatic and so happy for her. She's already feeling a lot better. But the point is that even if it's in 1% in common cancers, particularly, that adds up to a lot of people every year. In these uncommon cancers in which the fusions are pathognomonic, certainly that's easy, that's knee-jerk, but taking the time to sort of individualize for each patient, developing the right plan, takes discipline, as you mentioned, but it also takes us, sort of moving away from what we think an NTRK patient should look like. It can occur sporadically in anyone with a colon cancer, pancreas cancer, or lung cancer. You just need to look. I would say as the cost of testing goes down, that barrier is changing, as the ability for us to look across multiple fusions and multiple mutations is now backed by better and better evidence. Again, that barrier should be less, and we should really sort of push our systems to make that cleaner, to rely on less tissue, and to get answers faster for our patients.
Yeah, and I know this whole wave of precision medicine has now got it to where most insurance is covering these tests now with CMS support. I think about how many Chem 20s and how many screening CT scans I've done over my career where I got nothing back. It's normal or it's negative, and yet that hasn't slowed me down from ordering those Chem 20s and the CT scans. So I wonder if that's sort of the way we should be thinking about this. Shubham, why don't you give us your thoughts on this issue of testing and impact on patients?
So I think if you, exactly as Tony and Jyoti said before, if you don't test them, you won't find them. So I think really testing, and especially where you can really find it. I really think right now, at least for these fusions, tissue is definitely, you really want to find these fusions, otherwise you might miss them. You might get these false negatives. So I think RNA-seq is a very important factor in this. I think really like Tony was saying, we don't catch all these on DNS orally. RNA-seq, I really think is the missing part, which you can really make a robust, because the sensitivity and specificity of RNA-seq is far better. And we can really find that, when you're looking at a needle in a haystack, you really want to find that needle. You don't want to miss it. The second thing is, I think once you really pick out in these patients, especially with these rare tumors, again, like I said, the responses and everything are very gratifying to, obviously, for patients, also for the treating physicians, really, when you see these patients do better for a long period of time. So.
Yeah, so if I could add to what you said is that, RNA-seq is important. So it's important for you to understand where your test is going, where your sample's going, and that your shop is doing the appropriate testing in support of that. Is that fair enough?
Absolutely.
Absolutely.
Yeah.